This week we are studying Chapter 2 in Egans, and it is pretty jam-packed with entertainment and keep you on the edge of your seat kind of material. No, just kidding. It's actually kind of slow. But it's important information, so we'll try to make it as exciting as possible. It is good to know these the ways that we go about taking care of our patients, keeping quality care a priority, and making sure that we're using evidence-based practice. So it's good information. So we'll all be excited to go through it as best we can and keep it as entertaining as possible. So I hope everybody is having a good week. We'll start off with that. Staying safe and staying sane. I think that's kind of key with this whole quarantine. So my hat's off to everybody who is surviving this, because it's hard stuff. In our lecture, or in our PowerPoint for this week, for Chapter 2, there is a TED Talk that is linked here. It's a really good TED Talk about improving healthcare and what it means to take a problem and to try to make it better for future patients that come in, and make sure that we're taking care of people the best as we can. So if you have the time, I would encourage you to watch it. It's about 19 minutes long, but you can increase the speed if you need to, and just have it going on in the background. It's good information, and it might be a little more interesting than my information here. He's really good at explaining things. So yeah, check him out. Let's go ahead and get started. So our goals in this chapter are to learn about quality care and evidence-based respiratory care. Two big important things in making sure that we're taking the best care possible of our patients. So quality, I really liked this definition, is never an accident. It's always the result of intelligent effort. And I think that is a really important aspect when you're taking care of people's lives, you know? A lot of the time we're taking over their breathing for them, and sometimes it can become monotonous. You're doing the same thing over and over again, but when you're in patient care and healthcare, it's really important to be present in what you're doing. You know, that's kind of a big thing in our society today. We're learning to be mindful, and we're trying to be present in our situations, and that includes in our jobs. And making sure that we're providing quality care for patients is about being mindful of the job that we are performing and not becoming so routine and so monotonous in our procedures that we're not doing the best we can with every patient. It seems kind of overwhelming, and it is kind of overwhelming sometimes, to make sure that you're really doing the best you can for each patient, but that is the goal, to deliver quality care, which is never an accident, and it's always the result of intelligent effort. Assessment of quality is temporary because components of quality are constantly changing. You know, one thing that may have worked for certain patients in the past is not working so well anymore because we're learning new things. Medicine is evolving, pathologies are evolving, viruses are evolving. You know, it's a constantly changing process. So quality is like an escalator. You're either moving forward or you're moving backward. You don't ever just get to stay in the same spot. The improvement of quality, we improve quality in these areas with the equipment that's being used, with the people that are administering the treatment and using the equipment, and the manner in which care is provided. So one of my jobs in the respiratory program right now, I decided to take on cleaning out the supply room at the Davis campus, which is where our program is, my cohort's program is, and I cannot tell you the kinds of equipment and outdated tools that I found, such things as glass syringes that are not even used at all in practice anymore because they're not very safe. You know, can you imagine breaking off a cylinder or whatnot when you're using it on a patient? Like, that would be terrible. So I thought that was pretty funny. The quality is making sure that the equipment that we're using is the best and most up-to-date equipment. And that definitely was evident as I was cleaning out the supply room, because it was so interesting to find things from such a long time ago that nobody even uses anymore and could literally be put into a museum. So it truly is important that the quality of the equipment is up to date, that the people administering that equipment and treatments to patients are giving the best kind of material for the evidence that is out there, or giving the best kind of care for the evidence that is out there for our patients, and that the care is provided in the best way possible. So we'll kind of go over the important members of a respiratory care department. Starting off with the medical director, they are kind of the oversight of the whole department. They are responsible for clinical function of the department. It's usually a pulmonologist or an anesthesiologist. We have a medical director of the respiratory care program here at Weber State, who oversees the department of respiratory care at the school, and this particular person must possess both management and clinical skills. It's important that they're able to work with their team and with their department, but also to be able to work well with their patients. So this whole idea of, being super book smart but not being able to maintain social and people skills sometimes is not the best thing. You've got a doctor that may be brilliant but that can't hold a conversation, or can't go about a conversation without hurting somebody's feelings, may not necessarily be the best person for this job, because you really do need somebody who's going to be able to work with people. Not to mention, it's not really fun to be with a doctor who can't have good social and interpersonal skills with their patients. So that's a really big key component in taking care of patients and working with other people, is that you have to be workable, you have to be approachable, you have to be able to have good social skills and good people skills to work with your team and your patients. Your job is not to work on machines. Your job is to work with people. So that's excuse me. That's really important. So this box just lists the responsibilities of the medical director. You can go through and read that, things that they are in charge of and the things that they oversee. So you have the medical director, who is essentially the oversight of the program, and then you have the respiratory therapists, who are like the heart of the program, right? They're the ones who carry out the individual tasks, who take care of the patients. And quality respiratory therapists are educated, have good experience, and have good professionalism in their care. They are also the primary source of quality care. So like I said, the heart of the department. So they are what make up the success of that respiratory care program. Credentialing of respiratory care providers. They hold appropriate credentials. So they have to take and pass their boards. They have to graduate from a COARC approved school, and then they can sit for their board exams, and then as well as they need to have their state licensure, and keep up with their continuing education, making up good quality care for patients. Let's see, what am I trying to say? Respiratory care. In order to deliver quality respiratory care, you need to have proficient respiratory therapists, and that's essentially what this is trying to say. We mentioned that respiratory therapists, it's important for them to have good professionalism. So professionalism for a respiratory therapist can be defined as completing an accredited respiratory therapy program. They have their professional credentials. They participate in continuing education. They adhere to code of ethics put forth by his or her institution and state licensing board, and they join professional organizations. These are all things that add to the professionalism, and I feel like they make you more credible as a therapist. They make you be taken more seriously because you are putting your education and your training to work, and people take that seriously. It's important that you appear and that you are knowledgeable, so that when you're taking care of patients, people trust what you're doing, the patients themselves and the team that you're working with. So we talked about strong leadership skills, strong people skills, working with patients and with people. You have a manager of the department that usually provides kind of the technical direction. You have this medical director who oversees everything, kind of at the top of the food chain. Then you have the respiratory therapists, who are not the bottom of the food chain, but they kind of make up the bottom portion of the pyramid. And then in between there, you have a manager who provides the technical direction of the respiratory therapists and, helps to kind of facilitate communication between the medical director and the respiratory therapist. So they're the oversight, they're the in-between guy. They oversee policies, procedures, and equipment used to provide safe and effective patient care. Let's talk about protocols for a minute. So we've talked about what makes up quality respiratory therapy programs and departments. You've got the medical director and the technical direction, and then the respiratory therapist. So now let's talk about what those respiratory therapists do, what those programs are all about. I'm sorry, I feel like I'm kind of all over the place today. I hope that you guys can understand this. All right. So methods to enhance quality respiratory care. Protocols. Protocols are fantastic. They kind of standardize the type of medical care that we give to our patients. They are put in place to appropriately allocate respiratory care services. They act as guidelines for delivering appropriate care and treatments. And they represent guidelines to deliver care only when indicated by the correct method and to discontinue care when it's no longer needed. I think a lot of the time, I didn't think about how many different ways one person can do the same thing, if that makes sense. So for example, in our class that we're getting ready to graduate, we have 16 different people who are learning the same things, and all of us may learn the same thing, but do it completely differently. And so I think that idea can be applied in the hospital as well. You have all these different people working toward getting that patient healthy, but all those different people could do it in a different way. So having a protocol to do whatever that care is that you're assigned to do helps to standardize the care of our patients. It just kind of puts a one standard way to do something so that you don't have everybody doing things differently. Everybody can stay on the same page a little better. It helps to prevent errors. It helps to, for me, being a newbie, take away that, it gives a little more guidance, and it takes away that fear that you're going to do something wrong, because it's literally a map before you. Okay, this is what I need to do. Okay, since I did that, this was the result. What next? And the result says, okay, I either do this for this result or I do this for this result. And it's just a roadmap for care for your patient. And I think it helps standardize respiratory care, like I said, but it also provides quality care for our patient because we're trying to do the best that we can for them. This is a good example of that map that I was talking about. I'm holding my fingers up like quote unquote map, but you guys can't even see it. So sorry about that. But this is an aerosol therapy protocol. So let's go ahead and just work through this. It's indicated for patients who currently have a bronchospasm or a history of bronchospasm. And a bronchodilator is the type of medication that can be used. So those are good things to just take note of before you look through your protocol. So is your patient alert? If they are, yes. Can the patient take a deep breath? Yes or no? Is their vital capacity above the minimal amount predicted? If that's yes, then we go to here. MDI meter dose inhaler, that would be the bronchodilator. Is the bronchodilator therapy met? Or bronchodilator criteria met? Yes. Then the bronchodilator can be given with a spacer. If not, then a small volume nebulizer should be given with a mouthpiece. Good example of this would be like a child. For example, I have a 2-year-old, and trying to get her, she had RSV this year, and I'm pretty sure she's got some asthma going on. I have it, and so does my other child. But trying to get my 2-year-old to actuate a meter dose inhaler is a nightmare. There's no way that my little 2-year-old would be able to have the hand-eye coordination to breathe appropriately, to inhale the bronchodilator appropriately, hold down the medication. So there's certain criteria that need to be met, and my 2-year-old did not meet that criteria. So a small volume nebulizer with a mouthpiece would be the best form to deliver that medication for my baby, where, I have a 5-year-old who can give himself his asthma medication just fine with a meter dose inhaler and a spacer. So this criteria is a good tool to choose whether or not the medication is delivered with this route or with this route. So that's just kind of an example of the roadmap of aerosol therapy delivery and this protocol that's created to standardize respiratory care practices. Here's another one. I think this is just a continuation of aerosol therapy. So here's another example. A little clinical example. A 42-year-old male has returned to a medical surgical nursing unit from the recovery room after a cholecystectomy. He has no history of lung disease and is wearing a nasal cannula at 2 liters per minute. He is alert, oriented, and his respiratory rate is 18 breaths per minute. His heart rate is 82 beats per minute. When the respiratory therapist arrives to check his oxygen setup and pulse oximeter reading, his SpO2 is 97% on 2 liters a minute with a nasal cannula. What should the respiratory therapist do next? So, we are going to follow the oxygen therapy titration protocol algorithm. We're going to pull out the roadmap. Okay, we walk into the patient's room. Here's the vitals. Here's what he's looking like. Just a little bit of your initial assessment. Okay, what do I do now? So you'll pull out your roadmap, your oxygen therapy titration protocol algorithm, whether that's on the computer, whether you know it in your head. That is your tool to know, okay, what do I do next to make sure I'm delivering quality care and standardized care to this patient? The respiratory therapist removes the nasal cannula and returns in 15 minutes to recheck the patient's SpO2 reading, which is now 93% on room air. The respiratory therapist continues the oxygen therapy. So just a little example there. Key elements of respiratory care protocols: strong and committed medical direction, capable therapists, active quality monitoring, collaborative environment among respiratory therapists, physicians, and nurses, responsiveness of all participants to address and correct problems. So, keeps people accountable. It allows a standardization of care between respiratory therapists, physicians, nurses. It provides good quality monitoring. It makes sure that our therapists are capable in delivering good quality care. And it provides strong and committed medical direction to our patients, which is pretty important. So this is the event. This is the steps that are taking place to create a proper and quality protocol. I'll let you go through and read those. And then this is a standardized assessment that would be given to somebody, or that would be used as a tool to assess somebody. So you've got a lot of different people, like I said, who've learned the same things, but have learned in a lot of different ways. This creates just a standardized assessment for everybody to do it the same way, so everybody's on the same page in taking care of patients. So, like charting is a good example of standardized care. Keeps everybody on the same page. Everybody charts the same way, charts the same things. They don't chart the same way, but has the same options of things to chart. So basically it just helps to make sure that we are all on the same page as our patient, all on the same page as a team to take the best care we can of our patient. Here's another example of a consultation evaluation known as a care plan for a patient. So you can go through and check those out. I think it's nice to just see them, just to kind of put a visual on what I'm talking about here. So let's talk about monitoring quality respiratory care. We have these protocols that we're using. You know, we've established this way to care for the patient. Okay, well, we learned that quality is always changing, right? So how do we monitor those quality care principles that we've put into place? One method to monitor quality of care is to seek voluntary accreditation, and accreditation is given by the Joint Commission, and it is very important. So it gives validity to the hospital, to the caretakers, that they're doing good things if they're accredited by the Joint Commission. It's a healthy place to go and be treated for whatever you're going to be treated at a hospital who is accredited by Joint Commission. So this Joint Commission comes in and they evaluate your best care practices. They evaluate your protocols. They evaluate what types of things you're doing to take care of your patients, what mistakes are being made. They're a pretty big deal. And if anybody has ever worked in a hospital, when they know that Joint Commission is coming, it can be a pretty stressful place because everybody wants to do the best that they can. Everybody wants to make a good impression. So it's always a good thing to seek quality improvement, to seek constructive criticism on what you can do better. So that's kind of the way I look at Joint Commission. They're coming in and they're giving you props for doing good things, and they're giving you constructive criticism on ways that you can do things better. So continuous quality improvement, like I said, is an ongoing process to detect and correct factors that are hindering quality care for our patients. The AARC, which we talked about last week, the American Academy for Respiratory Care, has developed 4 goals that should be included in any continuous quality improvement plan. So specifically, just with respiratory, these are the goals that we try to stick to make sure that we're delivering quality care to our patients. We provide a method for ongoing monitoring for both quality and appropriateness of respiratory care, ensure that respiratory care methods and procedures are cost-effective, ensure that respiratory care methods and procedures are effective, and identify, rank, and resolve patient care-related problems. Competencies or checks are used to test skills and knowledge through use of clinical simulations. I don't know if anybody's ever really seen like the nursing clinical sim lab, or we have a respiratory sim lab as well. It's just a way to make sure that people know what they're doing, really, or to be a learning experience as well. You have a simulation that you put in place and you want to see what people do. You want to make sure they're doing things safely and appropriately, and if they're not, you want to teach them how to do it so that they can do it correctly when they're doing it on a human, not on a mannequin. So it's a pretty important thing that we have these simulations we go through. Maybe anybody who's taken BCLS or the CPR classes, you have simulations there where you practice, somebody witnessed a person go down, what do you do next? Or how do you start chest compressions, or how many chest compressions? That's just kind of an example of a simulation outside of a lab, but basically role-playing on how you would take care of a patient in that form of situation that you're being tested on. It's a pretty effective way to learn. It's very intimidating, but it is very helpful to get you to do something over and over again, that when the time comes that you do have to do it and it's important and somebody's life is on the line, that it's almost muscle memory, that you just know exactly what to do. You're able to do the right things in the right way at the right time. So it's really important. Here is kind of a checklist of skills that you would want to be performing. It's basically your grading sheet for that simulation, right? Like, these are the things that you should be doing, and this is the checklist that shows that you did the right things appropriately, you did everything that you needed to do, etc. Another thing that's important is to have these peer-reviewed organizations. You want to deliver quality care for your patients, but is it truly quality care if you're only doing what works in your hospital? Maybe another hospital is doing something that works really well there too, that's different from what you're doing, and vice versa. So being able to have this collaborative communication between peer organizations and being able to come to an agreement on best practice for patients and have these peer review organizations really make sure that we are taking care of people the best way that we can. It says that the federal government has established a pretty elaborate system of these peer-reviewed organizations to evaluate quality of care given to Medicare beneficiaries. You'll come to find that Medicare drives a lot of government funding and hospital funding, and it's a pretty important way to kind of evaluate healthcare through these Medicare patients. It's a way of the government being able to what am I trying to say? Like, track care and for example, let me just give you an example. That's probably a little easier for me. There is a thing called a reintubation rate. And if you have a COPD patient, for example, come in and they're sick and they, not reintubation rate, I'm sorry, rewind, a readmission rate at the hospital. So if you have a COPD patient who is on Medicare, comes to the hospital, is treated for their exacerbation or their sickness or whatever it is that they're sick with that time, and then they are sent home, if they come back to that hospital within a month of time, that the cost of the care for that patient is not reimbursed to the hospital. because that patient was admitted again within a month's time. So it gets kind of tricky because you want to take good care of your patient, but you also need to get paid. So there's this elaborate kind of middle ground where you want to make sure you're providing good quality care. You need to make sure you're getting paid so you can continue to provide care. And Medicare and the government are kind of a way that we're able to do that. Let's see, there's such things as accountable care organizations. There are groups of healthcare providers that work together to have peer-reviewed articles and peer-reviewed practices. And their goal essentially is to work to enhance quality of care, receive payment, like I said, and lower costs. So here's an audit. Somebody could come in and watch your quality of care, and this is where they would put their questions, comments, concerns, score you, etc. We've got hospital reconstructing and redesign. How can we best make our hospitals a productive place? And here are some common approaches to doing that. You want to cross-train your employees. Make sure people can do a common core set of skills to be able to best care for our patients. Using unlicensed assistive staff. I know for respiratory therapy specifically, hospitals in this area have started hiring what's called a respiratory therapy aide. And you don't have to have a certification or a degree. It's an unlicensed assisted staff that is able to help respiratory therapists better take care of their patients. Essentially, these aides can clean ventilators, they can clean equipment, they stock items, they're basically a second set of hands for that therapist. And at the end of the day, helping a respiratory therapist is helping a patient. So it's an effective way to deliver good quality, effective care for patients. And then decentralizing services, which is basically not doing everything the same way. So if you have a patient, you have these protocols, right? You want to standardize care, but you also have to look at your patient and base their care on that specific patient. Not everybody's going to react the same. Not everybody exhibits symptoms the same. So there's a very fine balance between using your protocols and treating your patient. So making sure that you are administering patient-focused care is also very important. So we've got disease management here. Disease management programs, they specifically relate to specific diseases. So a specific way to manage asthma, a specific way to manage diabetes, COPD, congestive heart failure. It's just an easier way to break down what would be the best way to handle those types of conditions. And it's really important, especially in the respiratory world, because you would handle a COPD patient that comes into the hospital differently than you would handle like a patient who has diabetes. And you would handle a diabetes patient different than you'd handle a heart failure patient. You know, there's specific ways that you want to take care of people with specific diseases, and a huge oversight isn't able to get down into those specific levels. So having these disease management organizations is really helpful to make sure that we're taking care of patients with their pathologies in the best way possible. And then evidence-based medicine. So this is kind of an important concept regarding quality respiratory care. It's using, like I said, when we're talking with, it's using that communication with different healthcare providers. It's making sure that what they're doing is working for them, and this is working for us, and we're working together to make sure that we're delivering the best care possible. And a lot of it is done through research. So you have these research grants, you have these people who are performing studies in hospitals to make sure and to see what we could be, to make sure we're delivering quality care, but also to see what we can be doing differently. Maybe this works and we've never tried this, for example. Our teacher was telling us the other day that there's a guy at the Mayo Clinic who is doing research right now about the efficiency of performing CPR with the head of the bed elevated. So typically when performing CPR, you have the patient completely flat and preferably on a backboard. But this particular doctor who's doing this research has found a 30% increase in the effectiveness of their CPR rates when they have performed CPR with the head of the bed elevated. That's something we have never used that I know of in this area. And if it works, obviously we want to do that. That would be the best practice for our patients. So that's a good example of using evidence-based medicine. You have, the scientific literature that's being produced, and we want to make sure that we're doing the best that we can for our patients. So this literature is produced, and then it goes through a lot of clinical trials, and then corrections and whatnot before it's deemed best practice. So it's very well researched, very well scrutinized, and once it's deemed to be safe and to be best, it helps to change the care of medicine. So it's a important thing to be utilizing evidence-based medicine. It comes from 4 different types of studies: single case studies, case series, cohort studies, and randomized control trials. And through these studies, we have new treatments, new medications, and new modes of ventilation that are being designed. So here's just some diagrams that show you some of the different ways that these trials are completed. And obviously, we study the outcomes of the trials. For them to be successful, they need to survive, obviously. They need to be discharged from the ICU. Meta-analysis is an additional tool of evidence-based medicine. It identifies, analyzes, and summarizes body of literature for a specific topic being studied. So this is evidence-based schematic here that kind of shows you the best way that we collaborate with all of these different facets of evidence-based medicine. You've got individual clinical expertise, best external evidence, and then patient values and expectations. And if we can find something here in the middle that kind of makes all of these areas happy, that's where we are able to truly move medicine forward and do the best that we can and be revolutionary in taking care of people and treating patients. So that is the end of our lecture. Kind of a long one. Sorry, I feel like I was very wordy today, so I hope that you understand. But that is pretty interesting. It's kind of dry when you're just reading it right out of the book. But when you see these principles and you see them in action in everyday practice, you start to realize how important, these fundamental principles are in quality care. So I hope everybody has a good week. I hope everybody enjoyed looking at the National Board of Respiratory Care website. And if you have any questions or comments, or if I said anything wrong and you need to fix it, or if you need clarification on something, please feel free to email me or Heidi. But other than that, we'll talk to you soon. Bye.